I think that a lot of people interchange personalized medicine with precision medicine. For the purist, I think there is some subtle differences. Personalized medicine is trying to use your genomic or other information that can be gleaned from other kind of tools that are laboratory based to derive a treatment specific for your cancer. In some ways, we already practice personalized medicine not based on genomics. We personalize our treatments based on patients' ability to function, what their kidney function is, what is their liver function is. But personalized medicine based on genomics is using your genomic information to devise a treatment specific for yourself. Precision medicine, for those who seek to differentiate it from personalized medicine, is that you are not actually looking at cancer of a specific histological type. You are wanting to become tissue agnostic and then look at the cancer from the perspective of the mutation and derive treatments based on trials that are designed to allow patients in with different cancer types to treat their cancer with a drug specific for a particular mutation or set of mutations. So in these paradigms, there are terms that are evolving that are also often confused. People use umbrella trials and basket trials as sort of interchangeable terms, but if you look at it, it is a little different. An umbrella is for one disease where you have patients, say with myeloma, who have different mutations, assigned different treatments, and you try to get different patients given different treatments have good outcomes because you know their genetics. Basket trials are when you are once again practicing the concept of precision medicine, where your basket is all patients with a particular mutation, and you're having in that trial patients with different cancer types, breast cancer, colon cancer, myeloma included, and they are the ones that then are studied as a single entity. And the hope is that in the future we will have regulatory pathways forward to allow for drugs to be approved for specific mutations and or genetic abnormalities, and not be limited to what we do today, which is approve drugs for specific cancers. So I think that these are, I think, for the purists, some subtle definition of personalized and precision medicine. I think that to answer the question posed earlier about why I believe that precision medicine is the future, I think that we are scientists, and we've always wanted to pursue treatments that are grounded in biology. The fact is that in the past we did not know how to study the biology. We now have tools that have been allowing us over the last decade or so to unravel the genetic information of myeloma at a population level, with now literally hundreds of patients having been sequenced. And this is, I think, going to allow us to get to that point where we can design the trials necessary. Now, we need tools that will allow us to do it beyond just the next-gen sequencing of exomes and whole genomes. Those are often still costly endeavors, but what we now know is we have next-gen sequencing panels by commercial agencies. But boiling it down further, there are now starting to emerge panels specific for multiple myeloma with a list of candidate genes that can be looked at. There are other moves afoot to look at the concept of personalized medicine in the clinic. So far, one of the things that has held back the laboratory aspect of identification of treatments is that we have in culture systems relied on cell lines which are not representative of human actual myeloma cells. But now more than one group, including ours, has produced the ability to recapitulate the actual tumor cells from a patient using their own microenvironment in a 3D structure that hopefully will allow us to better predict responses to drugs. This obviously still remains to be proven prospectively. And then the other thing is that our colleagues in the tech sector have moved one step beyond where we are already. They have already foreseen the problem that if you have a genetic mutation, how do you know that's the driver mutation? How do you know whether that's the only thing, if you target it, will lead to better outcomes? So they have started developing these platforms wherein they use the genomic information in proprietary platforms to create an avatar of the patient's disease, and then it's like getting all the symphony of the multiple genes that are mutated, translocated, to be able to guide specific treatments. And so I think that's the system biology approach. The beginnings are there. It'll still take a while to fine-tune these, but I think the potential is immense. I think as to the question of when will the fruits of all this research become translatable to patients' benefit, I think that we're already starting to see some of these examples of successes emerge. There are these what we call low-hanging fruit that we'll be able to pick in the next few years. But honestly, the full potential of the advances that we're making in basic science will take the better part of a decade or two, I think, to fully become translatable to patients. But I don't think we have to wait 10 to 20 years to see the beginnings of it. The beginnings, I think, have already been made.